Hello, and on behalf of New Wellness, it is my pleasure to welcome an international audience to the webinar entitled Multidisciplinary Approach to Fluid Overload Management in Complex Cardiac Surgery Patients. All participants will be in listen-only mode. After the presentation, there'll be an opportunity to ask questions, which may be submitted through the Q&A panel at the bottom of your screen. Participants are advised that the content of this presentation is being recorded for playback purposes. A replay of the presentation will be available in the New Wellness YouTube channel later next week. New Wellness is honored to host this educational webinar with an esteemed panel of internationally renowned physician experts who will provide valuable, provocative, real-world, science-based insights on treating fluid overload in cardiac surgery and critical care patients. Dr. Beckles is a cardiothoracic surgeon and the surgical director of heart transplant in Temple, Texas at Baylor Scott & White. Dr. Beckles obtained his bachelor's and master's in biochemistry and chemistry respectively from the Stony Brook University in New York. He obtained his medical degree from SUNY Downstate Health Sciences University, where he also completed a PhD in cardiovascular, molecular, and cell biology. Dr. Daniel Beckles is double board certified by the American Board of Surgery and the American Board of Thoracic Surgery. He is a fellow of the American College of Surgeons, the American College of Cardiology, and the American College of Chest Physicians. His clinical and research interests are in treating high-risk cardiothoracic surgery patients, including heart transplantation, minimally invasive surgery, ventricular assist devices, critical care, and translational research. Dr. Beckles is recognized as an international expert and has presented research in these areas. He is joined today by Dr. Maria DeVita. Dr. DeVita is the chief of the Division of Nephrology Department of Medicine at Lenox Hill Hospital in New York City. She is the training program director for nephrology within the Department of Medicine at Lenox Hill Hospital and a clinical professor of medicine at the Zucker Hofstra Northwell School of Medicine. She received her undergrad and medical degrees from Georgetown University. Dr. DeVita is recognized as an international authority in adult nephrology and hypertension. Her research and expertise focus on topics including glomerular disease, acute and chronic renal failure, dialysis, hypertension, and fluid management. She has authored and co-authored countless peer-reviewed clinical papers and serves on the editorial board as a peer reviewer for multiple scientific journals. She is joined today by Dr. Mehdi Aloumi. Dr. Aloumi is the critical care intensivist who serves as the medical director of the Adult Cardiothoracic Surgery ICU at the Mount Sinai Medical Center in New York City. He is an assistant professor of cardiac thoracic surgery and critical care. Dr. Aloumi received his medical degree from Tehran University, his internal medicine residency and pulmonary fellowship at Methodist Hospital Cornell Medical Center in New York, his critical care fellowship at Sloan Kettering Cancer Center, also in New York. Dr. Aloumi's clinical interests include critical care management with a focus on patient outcomes. He is an expert at optimizing the expertise of the cardiac team managing surgical patients in the postoperative period. He is passionate about critical care fluid management, reducing patients' length of stay, and positive patient outcomes. He has published peer review articles, book chapters, and is an international speaker on topics related to critical care. My name is Dr. Linda Hart, and I will serve as the moderator for the webinar today. I am an acute care nurse practitioner with research and clinical expertise in the areas of critical care and heart failure. I serve as the clinical education manager for New Wellness. Thank you to our esteemed panel for sharing your important research and expertise with the audience today. Here are our forward-looking statements, the speaker disclosures, and our agenda for today. With that, I would like to turn the program over to Dr. Mehdi Aloumi.
Good afternoon to everybody, although some part of the world is good morning. I'm just going to next few slides talk about the dangers of the fluid overload in cardiac surgery patient, particularly on their recovery phase. First slide, please. As you know, our goal is to keep the patient euvolemic because hypovolemia, by definition, reduction in the effective intravascular volume can create a serious organ dysfunction. At the same time, hypervolemia or volume overload, by definition, when the total body water increase, can cause the adverse outcome. Next one. If you see, related to the cardiac surgery, that's a relatively old study, around 12 years back. But if you see predicted effect of increased intravenous fluid by itself as a variable, increased significant mortality in cardiac surgery patient. If you look at the graph, the top, the patient who has the acute kidney disease at that time, because AKI was not well defined till 2014, and the hypervolemia, if you see it, the patient on the x-axis, when they are hypotension, significant mortality is high. At the same time, if the patient does not have an AKI nor have a hypotension, but just as an indicator they be hypervolemic, the incidence of the mortality is higher. So it means it's going to be as a one variable is going to determine the outcome of the patient. Next slide, please. If you look at the effect of the hypervolemia, so let's start it in the brain. We know when the total body water is increased, definitely we're going to have a brain edema. And there's some hypotheses regarding of the genesis of the delirium or mental status of the patient change significantly post-open heart surgery. Second, the effect of the heart not only is going to have a diastolic dysfunction, we have a series of the evidence that the hypervolemia might contribute to the conduction system, particularly put a strain on the atrium and the genesis of the atrial fibrillation, which we see it after open heart surgery. On the lung, definitely pulmonary edema is the one extreme and the gas exchange. On the kidney is quite important that the venous congestion, hypervolemia by itself, it can cause or generate the AKI. It means perfusion of the kidney is going to decrease, at the cellular level, and it's going to be a salt and water retention. On the GI tract, on the gut, basically is going to generate this ileus for a patient and malabsorption. On the liver, we know it's going to generate some cholestasis. And then definitely on the peripheral tissue is going to total body water when it's increased, we have a higher incidence of the pressure ulcer. Next slide, please. In this two slide, if you see on the left graph, because nowadays we look at the quality index and the length of the stay that the length of the patient is staying in the intensive care unit, hypervolemia by itself is increased, not only the length of the stay patient in the critical care, is increased of the length of the vent dependent. So it means not only patient is staying in the ICU longer, on the right side graph is showing that the patient gonna be significantly vent dependent. And the effect of it is gonna be on the both right side of the both graph is showing it significantly. The longer patient is hypervolemic, the longer is going to be on the vent and they're going to stay in the ICU. Next slide. Fluid overload. If you look at it, actually, the nice study was done, is around 2014, is a regression analysis and they published in this Blue Journal. If you see 1 out of the 5 cardiac surgery patients, they are going to be admitted secondary to hypervolemia within the 30 days. And then is the number 1 cause of the admission after 30 days. So if you generally, if you see, we try to condense it, or the paper, they try to condense it, 1 out of 5 patients who get the open heart surgery, it's a chance of the admitted either within the first 30 days, which is relevant to the arrhythmia and infection is a little bit less, but the number 1 cause of the admission of the patient after 30 days. And it's important because nowadays, Dr. Beckel is going to emphasize this, we're doing a more, higher risk patient with the heart dysfunction and this chance of the hypervolemia, we have to be aware. Next slide, please. I think before that one, should have one slide, a prior slide. Okay, next slide, please. All right, this one I just want to see is the last study we wanted to say, if the patient has a congestion or volume overload, this is a combination of the 2 studies we're looking at it. On the x-axis, on the left slide, is the CVP pressure. That one was done comparison with the other parameter in the Swan GANs that we can obtain. The one variable is going to determine the outcome as far as the mortality of the patient in open heart surgery is a CVP by itself. And it's interestingly, if you look at on the right slide, the CVP when gradually increased from the normal range and then the higher range, this significantly is going to change the outcome of the patient, especially if you see the x-axis is a follow-up time is based on the years. It means staying the hypervolemia of the patient not only is going to have an effect immediately post-open heart surgery, it has a long effect for our patient. I just finished with this state that if we define, particularly in the cardiorenal syndrome of the patient and the cardiac patient that we looking at it, if we define congestive heart failure, like a cirrhosis, is those patients, they have a low effective intravascular volume, but they have a total body water is significantly increased. If you see hypervolemia management, which we obtained since last 2000, has a significant effect as far as the outcome. And this heart failure literature is emphasizes, it started from the diuretics, ACE inhibitors, neprolizing, and nowadays is the diabetes management. Thank you very much.
So I'd like to, this is Dr. DeVita, and I'd like to discuss the challenges of managing fluid overload in cardiovascular patients and in those in critical care areas. Next slide, please. We're well aware that you get the fluid buildup, as we just heard, but I think we're focusing more on the venous congestion component of the renal outflow as opposed to the head of pressure going into the kidney. So with the first bullet, in many patients, venous congestion rather than arterial underfilling is associated with decreased renal blood flow and worsening renal function. This is an interesting newer area of research that we're following. Renal perfusion pressure depends on the arterial pressure and the transrenal perfusion pressure. So the transrenal perfusion pressure is equal to the MAP minus the CVP. So intuitively, it makes sense. And the kidney is all about pressure gradients and concentration gradients. And if you ever have pressure or concentration equilibrium, nothing much has happened. So the whole way the kidney operates is always following gradients. I mean, there is some active transport going on, but a lot of it is just the gradient. So this is a big area of interest. So for the third bullet, the venous congestion is the strongest hemodynamic determinant for the development of worsening renal function. And right ventricular failure leads to the venous congestion. And if we relieve that congestion, and it leads to an improvement in the renal function. Next slide, please. I wanted to go over for the audience the DOSE trial, which was a study already about 10 years old. It was actually published in 2011. And the DOSE trial was the diuretic optimization strategy evaluation study. And basically they had a 2x2 study where they used furosemide to diurese people with acutely decompensated heart failure. And the groups were a bolus dose of the diuretic or a continuous infusion of the diuretic, also compared to low dose of the diuretic and the high dose of the diuretic. The low dose was what their home equivalent was in intravenous form, and the high dose was 2.5 times their home dosage. And as you can see, depict on the right hand side, on the figures on the right side of the slide, panel A is the bolus versus the continuous infusion, and it's the proportion of patients and then the number of days. And you can see there really was no big difference between the continuous or the bolus infusion. Panel B is showing the low dose versus the high dose strategy. You can see that there also wasn't a big difference between those two dosing regimens. So it's sort of saying that we've maxed out a little bit about the diuretics. I will say over the 10 plus years since this has been out, one of the criticisms of the bolus category is that they didn't, one criticism of the continuous arm is that the patients were not loaded. So they didn't get a bolus dose and then started on the continuous form. And that was, I think, a big fault of the study, because if you're just giving somebody a diuretic drip at 10 milligrams per hour and somebody else is getting 80 milligrams at the start, you're not getting that jump start. So if you're ever using a diuretic drip, it's imperative that you give a bolus dose and then start them on the drip, just for general information there. Next slide, please. So diuretics, as we've been talking about, play a central role in the management of fluid overload. Diuretics have a lot of side effects and adverse effects. So basically, the longer you're on a diuretic, the more you'll become diuretic resistant. So over time, they become less effective. There's a high incidence of poor diuretic response. Among heart failure patients, 40% show poor diuretic response and 68% show suboptimal response. High risk and rehospitalization within 30 days is very common, 24% within 30 days and 50% within 180 days. Other clinical events that happen is you have increased risk of worsening renal failure and accelerated kidney function decline. You have a lot of electrolyte abnormalities. Most commonly are azotemia, metabolic alkalosis, and hyponatremia. And then you have a higher risk of mortality. How much of that is diuretic driven versus the actual condition is not clearly understood, but it all goes together with the diuretics are not doing as good a job as we would like them to do in this population, and we need to figure out a better way to wring them out. I tell my patients they're a wet towel and we have to wring out all the extra fluid. So on this next slide, we have now, I'm a big proponent of ultrafiltration. We're trying to find its perfect niche, and that's what this webinar is all about. But ultrafiltration is a mechanical diuresis and natriuretic tool. So it's going to get rid of the volume, but it's going to get rid of a lot of salt. The fluid removal by ultrafiltration is very controllable and adjustable. The ultrafiltration extracted through the convection forces removes significantly higher amount of sodium compared with hypotonic urine produced by diuretics and other pharmacologic agents. If you look at the panel on the right-hand slide, you'll see that the y-axis is sodium, the x-axis is, if you look at the right two panels, I want to focus there, but the diuretics will lose about 60 to 80 millimoles of sodium per liter, whereas the ultrafiltration, it's a pure ultrafiltrate of the plasma. So whatever your serum sodium concentration is, that concentration of sodium will come out into the ultrafiltrate. So it is twice as efficient in certain occasions than a diuretic. The other point, the second bullet point, I think is also a major strength of the ultrafiltration. I feel that the diuretics you give, you're not sure what the dose is, you're not sure when it wears off, and how are you going to titrate it. So the fluid removal by ultrafiltration, you can just dial up a urine output is what I tell people. How much fluid do you want to remove? You sort of can increase it for 2 or 3 hours. You can then decrease it, and you can really manage it much more quickly than you can with the diuretic. So those are all advantages of ultrafiltration. Next slide. I think my time is up. We'll pass it along to Dr. Beckles, and I'm really excited to hear about his study.
Excellent. Thank you very much, team. This is Dr. Beckles, and good morning to you all. And for some people, it's already afternoon. So I will present our published data looking at the experience with ultrafiltration in complex cardiac surgery patients, specifically in cabbages. So next slide, please. So a little background. CABG is the most common heart surgery performed in the United States and Canada, accounting for about 55% of all cardiac surgery cases that are done and monitored by the STS. Many publications have documented this high morbidity and mortality associated with this fluid overloaded states, as highlighted by my two previous colleagues. The well-accepted national and international evidence-based enhanced recovery after cardiac surgery program, they recommend using goal-directed therapy to avoid excess salt and water IV infusion and to maintain euvolemia as much as possible. So next slide, please. So according to the recent STS data, looking at 2019 on your screen, this is published every year. You can see here that the renal failure highlighted in red. The incidence of acute kidney injury is as high as anywhere from 40 to 50% incidence. But in this Society of Thoracic Surgeons database, it shows that the mortality for pure cabbages on your extreme left column is 2.2% for 30-day mortality. And renal failure rate is almost the same, 2.2%. So that's about, if you calculate the total number of patients, that's about 3,560 patients out of 160,000 patients that undergo coronary artery bypass grafting. Next slide, please. Actually, I want to mention, go back to the other slide. Please, thank you. If you look at the rest of the columns, it highlights all the other procedures that are done in the cardiac surgery realm, and that's aortic valve replacement, mitral valve, and although this data today we're discussing high-risk coronary artery bypass grafting, it can be used for any other conditions within this field. Thank you. Keep on going. So I'm going to discuss the framework for this study. And it was performed at a single institution at one of the 8 Baylor Scott and White cardiac programs located here in Central Texas, and serves as a hub and spoke model of cardiac surgery care for high acuity patients. And also, this study was done during COVID-19 period from January 2020 to July 2021. So just bear that in mind as a framework. Cardiac ERAS protocols were already in place, utilizing an evidence-based structured approach to pre-op, intra-op, and post-op cardiac care. And in the post-op cardiac surgery space, patients were monitored using standard monitoring. We use Hemosphere, Edwards Life Sciences, Swan-Ganz, and FlowTrack monitors CVP and cardiac output, cardiac index, SVR. A multidisciplinary team approach, including intensivists, like we have on this panel, PAs, renal team, and surgeons were made on patients in a 24/7 care model, just to, again, highlight the framework. Of the 254 charts of these patients undergoing coronary bypass grafting, 17 required ultrafiltration to help them and help to decongest their system. That will be discussed. Next slide, please. So when we look at the methods, access for ultrafiltration, there are many different ways in order to actually obtain access. Ultrasound technology and expertise is always available in our ICU, depending on the timing and need for ultrafiltration, which is on average always within the first 3 days post-operatively, according to our data. We mostly use the access placed by the anesthesia team for adequate flows without any problems and no additional access. If we do need additional access, we use peripheral lines. Diuretics are held once ultrafiltration is initiated. And again, this is to just rest the kidney during the period of decongestion. Anticoagulation is a non-therapeutic heparin protocol placed towards the filter in order to keep the filter patent. We have not had any problems using this protocol with wide range of ultrafiltration, anywhere from 100 to 500 cc's an hour. In the post-cardiac surgery space, it is ideal for using routine post-operative monitoring devices. So all of the different monitoring equipment is there in the same space during this period of time. So good targets as shown here, an expectation on rounds were for fluid removal until a return of clinical euvolemia. So depending on the patients, how they present, getting a net volume, I think we had about 2.6 liters per day in our net volume. CVP, of course, less than 12, decreased oxygen requirements. All the signs and clinical symptoms of euvolemia is what we target as our end goal during this therapy. Next slide, please. In the paper, we discuss all 17 patients individually and give clinical scenarios for each of them. You can see here from this table one, the demographics age range from 41 all the way up to 89, and EF range also from normal 65 down to 5% EF. The other demographics of clinical, 88% of our patients had hypertension. A larger statistically number of patients, near statistically significant, had diabetes. 76% of them had diabetes. And so that's all explained in the paper. Next slide, please. Our EMR is an Epic system. And these are the types of ins and outs that we track and trend every day on these patients to ensure that we have a net negative fluid balance in combination with daily weights and the clinical status that we discussed on the previous slide about euvolemia. Next slide, please. So our results were surprising but consistent with these findings, and as explained by my co-team here. The mean fluid removed was about 2.6 liters per day. And for this high-risk cohort, we saw a 30-day zero mortality rate. In some patients, we had 3 out of the 17 patients that were already on preoperative hemodialysis. We use intermittent CVVHD for clearance when needed in collaboration with our renal team. These are consensus formed on rounds. Some of the many benefits of this UF technology is that it's immediate therapy. It can be set up easily. It pulls off fluid within 30 minutes, starting to decongest the patient. And I think venous decongestion of the patient is critical for success. So very simple to set up and very user-friendly. Next slide, please. So I want to conclude here that cardiorenal syndrome is an inter-organ pathophysiological relationship in the setting of fluid overload. Elevated CVP is associated with renal congestion, as shown by this entire webinar. It can lead to renal dysfunction if untreated or left untreated or in a timely manner. Ultrafiltration post-op removal of isotonic fluid safely and lowers the CVP, thereby maximizing renal recovery. Simplified ultrafiltration is safe, efficient, can be used in high-risk patients as in our patient population. Quick to set up, low extracorporeal volume, 35 cc's in the entire circuit in case it gets wasted for whatever reason, and to avoid blood loss. No immediate need for renal consult, but we consult our renal colleagues routinely in case it escalates into needing advanced CVVHD or hemofiltration. Existing venous access placed intraoperatively, very simple. We use the same access line if it's within 3 to 4 days of the procedure. We can still use line, but we can put additional peripheral lines as needed, and it's managed by the ICU nurses 100%. So no additional staff is needed, and that turned out well during short staffing issues and with the COVID pandemic. Hourly outputs are recorded on the machine itself, so the nurses are not preoccupied writing and making calculations. So there is no calculations to be made, just the machine shows the exact amount removed and a total amount at the end of the shift. Thank you very much for your time. And we're gonna go into a deep discussion with all our panelists.
Great. Thank you all so much for that very wonderful presentation. So I have a few questions here, and certainly open it up to the audience as well. Again, you can either use the chat or the Q&A to ask questions. But it sounds like Dr. Beckles, when reading your manuscript, which thank you so much for publishing that so that you know exactly how this therapy is used in this space. It sounds like a playbook really for these complex patients, sort of a recipe and that sort of thing. So I'm wondering, in patients that aren't quite as complex, how do you see this therapy fitting into the sort of armamentarium that we have to treat fluid overload and expedite patient outcomes?
That's a very good point, Linda. And so besides the regular pre-op assessment that we do on all patients before surgery, a patient can start off, as you saw in our table with a normal creatinine, and we assume that that patient is going to be low risk STS score 1% or less than 2%. And, by the time the patient get to the operating room and post-operatively, if you recalculate that score, you use a continuous moving risk score, like the Parsonette score, you will see that these patients are actually high risk by the time they're encountered in the ICU. And what happens is it's a multifactorial problem that can happen to any patient, so low risk or high risk. So it's good to have technology available for these patients, not just for the high risk patients as in our group, but for all comers and for patients who you least expect that would need it. So I think it can be used in any fashion. Using the word low risk cardiac surgery today, as highlighted, patients are coming in much more sicker, and until they go through the operation and come out in the post-operative space, we never realize it until, especially since they all have a high risk of AKI, 30–40% risk of AKI is pretty high. So which way they would go, most of them recuperate, which is great. 17 of our 254 patients needed extra help to decongest them. Technology could be used for either one.
Great, thank you so much. And so sort of trending on that same thought line, I'll direct this question to Dr. Alumi. In terms of the critical care setting, these patients come to you post-operatively, and then what is your algorithm or your pathway that you use to determine, when to start, or who's the right patient to start to use ultrafiltration with Aquadex? How do you determine that?
Very good question. Traditionally, we used to think the AKIs happen and the patient has a consequence of it. They might have a salt and water issue and we have to address it. Nowadays, probably last 10 years, the idea gradually changed, which honestly, we have a very restricted protocol. We address the hypervolemia very seriously. And we thinking as a whole group that the hypervolemia by itself can induce AKI. So it means the volume status, as Dr. Beckel says, we take it seriously. And those who we don't get the predicted response, extra help, the sooner the better would be. I'm glad actually to Dr. Beckel publish his paper. At least now we know it as a fact, but the trend of the thought has been, and I'm seeing it recently, many centers, they try to address this hypervolemia. To answer your question in one sentence, hypervolemia has to be addressed on the day 0 as soon as they come to the ICU. And if you don't get the adequate response, has to address it fast. If they need some extra help, then we're going to look at it.
Great. And so just to clarify the adequate response, how would you best define that? I mean, are you doing a furosemide stress test? Are you looking at their urine sodium? How do you determine what their response that you want would be?
So if we know the patient from before the operation, certain group of the patient, they have a higher chance. For example, if they have a right heart failure patient, they have it. Or the patient, they have some persistence of the presence of the chronic kidney disease. Problem with the diuretics is a time delay. Time is the essence. So sometimes you give a Lasix for a patient, and then you're going to see what the patient is doing it. Nowadays, back to your question, is this Lasix challenge is going to determine the outcome of the AKI on the recovery phase. So in Sinai, the place I am working at, we are very adamant on the high-risk patient, those who get the assist device, they are more prone for the RV failure. Sometimes within 24 hours, very fast, we try to remove this volume status, so to address that. So yes, we give a diuretics and we look at the response of the patient, but it's not something to see what's going to happen with the diuretics and the next day you see how the patient responds. So we are looking at it and we are very aggressive as far as the fluid management of the patient.
Great. So really early identification and then early implementation of this tool.
That's right.
Can I ask a question just dovetailed into to both of my co-panelists? Is what type of a line are you guys doing? Because I'm sure that I think that would be important for the audience to, the device is great and it works very efficiently. We all agree on that part. I think one of the rate limiting steps has always been the access, and when do you decide to to put the access in, I think is the bigger part of the decision, if you will. So why don't you, could you both each tell us sort of how you decide that and what type of line do you use?
Go ahead, Dr. Lumi.
Sure. In the place we have a 24/7 intensivist in our program, and then inserting the line is a part of like honestly, it's a daily job. So we usually use the shyly. Having said that, on a certain patient, we have been creative too. It means, although it's not published, but honestly, we use it several times, including last week I did on one of our patients. Sometimes if you have a big, like a MAC line with a different port, we're pulling from one port and we give it back to the other port. To answer your question, Dr. DeVita, as far as the line, we use the big French dialysis catheter and we are very aggressive. If the patient needs it, the patient gets the line.
Great.
I want to echo that same response too. We use the anesthesia MAC line that's put in the operating room that has a center where the swan is usually, but those two side ports used frequently as an initial first step. Again, if you're in a high risk space, lines should never be an issue. If we're operating on these patients to get the best outcomes and resource utilization, we also have 24/7 PA coverage to put lines in very easy. We have ultrasound in the ICU. So I advocate that although this is one of the biggest steps forward is who's going to put the line in. Once you have a patient like this that's in extremis and fluid overload, they have a very high mortality rate if you don't get someone or some system in place or process to put these lines in.
Perfect. So great. So a question for you, Dr. DeVita, as you're caring for these type of patients or critical care patients, the question always comes up, we're monitoring CVP, but people get very nervous about creatinine levels, serum creatinine. And we know that so much of AKI and worsening AKI, as you alluded to, is related to this venous congestion. So what advice would you give us in terms of looking at creatinine and sort of what is your markers that you use for determining, when to use this therapy?
Thank you, Linda. It's somewhat of a complex interpretation of creatinine because creatinine could bounce around or jump up just with a momentary drop in renal perfusion. So even though we're talking a lot on the venous congestion side, there is still the possibility of having a decreased perfusion pressure going into the kidney, and that certainly would make someone more azotemic. If you are pulling off fluid too quickly, then you could establish ischemia within the kidney and develop an acute kidney injury, an acute tubular injury. So we watch for those things. So clinically, we apply it. The way we track whether we're using an efficient rate for the ultrafiltration rate is to monitor the patient's own urine output. The kidney is still a very precise marker if it's working, and in most of these cases, the kidney is still working, to changes in renal perfusion. So if the urine output is 50 or 75 or 100 mLs an hour, then it goes down to 20 or 30. The kidney is already sensing a decrease in renal perfusion. So then we would back off on the ultrafiltration rate. Now, if they're having other reasons to have an acute kidney injury, for instance, they hemorrhaged and they needed transfusions and their blood pressure was low for a long time, they got some toxic insults in terms of antibiotics, then you sort of have to decipher whether this is an intrinsic kidney injury due to some other insult, or is this just perfusional things. So the take-home message and all that is to really watch the urine output closely in these patients. And if the urine output is dropping, then you might want to reduce the UF rate. And don't worry so much about the creatinine in and of itself. It's going to fluctuate. There are a lot of things that affect the creatinine, and a lot of the literature out there now shows that for those patients who do bump their creatinine, it means that you are decongesting them a little bit better, and perhaps and they will have better outcomes in the end. So so the creatinine change of a 0.3 or a 0.5 or even a 0.8 isn't as worrisome as it was 5 or 6 years ago.
Perfect. That's great advice with the creatinine. So, and particularly with that new information out there. So going back to Dr. Beckles, I know that you indicated in this particular body of research, your anticoagulation level. If you could just sort of talk a little bit about how you manage anticoagulation, because you think about these are post-surgery patients, and maybe that dovetails into how often do do you use the ultrafiltration therapy sort of per patient? And then talk to that, to the anticoagulation, and then how long you typically run these patients.
Absolutely. So patients coming out from open heart surgery, instead of putting them on sub-Q heparin or Lovenox, 100, just putting them on 400 to 600 range units per hour of a heparin drip towards the unit, towards the filter of the device. There are two small access ports on the tubing, and if you just infiltrate the heparin towards the filter to help prevent filter from clotting, works great. So we're not shooting for a therapeutic range at all in the patients. We do check PTT, PT-INR, because if these patients have liver congestion, etc., you can actually see that they have either leftover heparin from the surgery, but we don't shoot for therapeutic on these patients. And it's worked great and remarkable in the study and in my previous 5 years using the device. Haven't had any complications of clotting. And if the system does clot, it's only 30 to 50 cc's of blood. So for those Jehovah's Witness patients, works great. So you're pretty much conserving blood. If the patients have a low platelet count and you're suspecting HIT, again, in these high-risk patients, not a problem. Just put them on, a Gatroban, and you can shoot for a lower than therapeutic range again. So we haven't seen any reason to take the patient back to the operating room for bleeding because of ultrafiltration or its anticoagulation during that time. In fact, it should help decongest the liver and improve your coagulation profile, if anything, theoretically.
Fantastic. And then Dr. Alumi and then Dr. DeVita, if you all could comment too on how you run your patients in terms of with the question of anticoagulation.
Sure. As far, I'm almost mimicking, interestingly, what Dr. Beckles does. So we are not chasing PT-PTT. Rarely, personally, go more than a 500 unit of the heparin. And those who are high risk for coagulation, if we have an issue, we go with the insurer, we go with bivalirudin. Very low dose through the filter that we give it. Rarely, I honestly, I don't remember I have any complication as far as the bleeding. And if the blood loss is significantly compared to the other modalities, the renal replacement therapy is very minimal through the circuit of the aqueducts.
Perfect.
And we're still doing the old traditional way, but I think I have to up my game.
Yes, you do.
Very good. Well, have your results then been favorable, Dr. DeVita?
Yeah, we haven't had any bleeding, and I would say that we don't chase like the others. We don't really chase it, but we sort of don't have it right at the port. We'll sort of use the heparin. We have a sort of a low dose systemic anticoagulation protocol built in. We have on occasion used no heparin in a few patients if we just need to use it for a few hours, and it tends to work fine. And if somebody's already with some other problem with bleeding or not quick to clotting, then sometimes they get away with no heparin at all. So we sort of keep that in mind. But I would say that part of the equation has never limited the use of it. We sort of figure that out as we go along.
Perfect. Great. Well, I know too, and this to Dr. Beckles and Dr. Alumi, oftentimes we hear that cardiac surgeons run their patients dry, right? And then we know that they go into the intensive care unit, and certainly having a surgery, any kind of surgery, and particularly cardiac surgery, is such a huge insult to the body and this whole inflammatory cascade. So when you're thinking about people that say, well, I use it dry, so I don't really see the relevance of this therapy, how might we be able to anticipate that or really educate our audience to figure out where this would fit in with somebody that might have that particular philosophy or practice style?
Yeah, absolutely. So, again, I think we're seeing a lot of variation in care. Some groups would run their patients dry, and that can also lead, as Dr. Alumi showed, if you're too dry, then you can also get AKI if the patient is in high demand from the cytokine storm. You need to quench that ebb and phase of inflammation during open heart surgery. So again, if programs run patients dry and they don't need this and they have great outcomes and don't see AKI, then there's no need for this. But unfortunately, that's not the majority of cases. Majority of cases that we see, especially if they have complex valve cases, higher risk patients, multiple valves in valve centers, all the centers that we're talking about do more than 600 cases a year easily. And in these centers, this is what we use for any patient that gets into fluid overload states and not responsive. I want you to go back, Linda, if you can go back to slide 23, where I showed the patient demographics, and just show that, in that slide, we showed the preoperative creatinine, just to go back to that question on how does creatinine play a role. You can see that the pre-op creatinine, even some patients had normal pre-ultrafiltration creatinine and still was in trouble in terms of hypovolemia, high CVP, high oxygen demand, trying to get them off the ventilator. So patients are not just coming in with just kidney issues, it's lung issues, it's heart failure issues, it's multifactorial what they're coming in with and what state they come in with. Again, this is a very high risk population when the STS co-average is around 5%. It's it's 5 times the normal for most places.
And then I'd like just to add to that, just the thought is that I think we all sort of want them to be euvolemic on a little bit on the dry side, so the goal is we sort of want them, we don't want them volume overloaded. So the question is, can you get there? So like Dr. Beckel said, it's like, well, you want to get there immediately, and how much time do you wait, and the diuretic will work or not, or you just sort of know you can control the situation with the aquapheresis is sort of the bottom line. But I think we all want the same outcome. We just sort of don't want to knock off the kidney. We want to make sure the volume, we want to decongest them, and we want to do that as efficiently as possible. And some patients don't need it, but where they do need it, it's a very wonderful tool, as Dr. Beckles has shown in his research.
Yes, it is.
Great. Well, let me ask the panel this too, because you all are at very large teaching hospitals. I'm sure your volume of even doing hybrid structural heart procedures, your TAVRs, your mitral valves now in the tricuspid area. How do you see Aquadex playing a role in those sorts of therapies? Because oftentimes, those patients, not maybe so much the TAVR now that it's sort of become more of a standard of care, but particularly some of the other hybrid procedures, oftentimes, these are patients that are a little more fragile. And so how would you recommend we look at those patients and maybe incorporate this into what we're doing?
I think it applies through the entire spectrum of any patient that's actually fluid overload. We have used it on thoracic cases, any patients that actually is in a fluid overload state that has AKI and not responding to diuretic and regular treatment. It is a huge safety net for those patients. And so in the structural heart space, most of those patients also have fluid overload or right-sided failure and come in chronically congested. And after fixing the valve, especially mitral valve and clips, this is a great tool for them, and to have it as a safety net.
Great.
And then I'd like to add, it's also a way to look at it is it's almost like a race. You really got to decongest them. You want to decongest them immediately. So I sort of approach it with my group is, well, we want them to be this much negative by X o'clock. And you sort of titrate the diuretic, or we sort of see it's not working, you're going to switch very quickly to the Aquadex. So it's more of like, like there's there's a lot of data you have to have them extubated in 24 hours and they have much better outcomes and whatnot. So we're sort of getting this decongestion data out there. So how long will we wait versus how aggressive should we be? And I think we're sort of leaning the other way. It's very important to decongest people quicker, and now we can control that.
Yeah, very important. I think as you look at IV, we can increase pressors by the IV pump. We can increase and decrease oxygen flow based on how the patient's doing. So I loved your analogy of basically being able to do the same thing with urine output.
Personally, when we do the round for our fellows and the resident, we look at the model. The urine output is like a blood pressure. So it means we are going to check it sometime, believe it or not, every 5 minutes, how much patient goes up. We want to bring the attention of the trainees, how the patient urine output is important. And then we try to address the issue. As you said, time is the essence as far as the outcome in intensive care unit. and cardiac surgery. So there's two important issues: the urine output of the patient, assess the volume, and then try to achieve the results that you are looking at it, instead of to wait and see what the next day patient is going to do.
Great, perfect. Thank you so much. So in our little bit of time that we have left, and let me see if there's any question. Here we go. One question from the panelists or from the audience. What about performing Aquadex before complex cardiac surgery? Can you all talk about if you've done that and how that might be play into a treatment plan?
For our center, actually, those who get the answer is yes. And then we use series of the case before the assist device. When you put the LVAD, because they have a RV dysfunction, and then we optimize them. We have used it on non-device, those patients who has been end-stage renal disease, and they come us, we call it pre-op optimization. And routinely nowadays for complex mitral valve, we bring sometimes the patient in before the operation to optimize the volume status. If I have two cases, if we do not achieve by the diuresis, we use the Aquadex before the operation.
And Dr. DeVita, was there something that you?
No, I was agreeing. I was just nodding in approval, but we don't. I don't have any experience on that.
Yeah, and Dr. Beckles?
Absolutely. We use it for our heart failure, pre-VAD, post-VAD. Again, very routine once you have it for as a safety net, but it's also part of that preoperative optimization strategy that's highlighted more so than ever before. So absolutely.
Great, fantastic. Well, in our few minutes left, I just want to do a little bit of a recap and then give each of you an opportunity to give the audience, if there was one or two pearls you would give them about either starting a program or using this therapy, what it would be so that they would have success with that. So we certainly talked about, the research were certainly these very, very sick patients, but certainly from our discussion, this is a therapy that can be used all along the continuum of someone diagnosed with some sort of structural heart problem that would require some kind of intervention, whether hybrid intervention, percutaneous, or surgical intervention. And really being very mindful of the urine output. I heard that set from each of you, that how important it is to look at the urine output and then use that information in tandem with what we're doing with the Aquadex. Also, not being so afraid of the creatinine, that is an indicator that the kidney is actually doing what it's supposed to do. Certainly coming alongside with our multidisciplinary team of nephrologists and intensivists, cardiac surgeons, cardiologists, so that we can all collectively manage these patients together. And then really using this sometimes to preoperatively to optimize, and then also postoperatively to obtain euvolemia, with the important notion of early identification of these patients so that we can get them optimized, because we know the longer they have fluid overload, then that just increases their morbidity and mortality risk. We talked a little bit about lines, and it sounds like the central line is what you all are familiar with in the patients that you're treating in the intensive care unit. Certainly using anticoagulation, but not necessarily at full dose. You've had success with that. So with that, let me start with Dr. Alumi, and what pearl would you offer the audience in terms of using this therapy?
Just 3 bullet points I just want to say. One, the reason we measure the creatinine to get the estimated GFR. So creatinine by itself, it does not have a value. The urine output is going to significantly give us more information. Second time is the essence. And the third one now is at least the pathogenesis of this whole kidney injury and hypervolemia, definitely in cardiac surgery or cardiac surgery associated AKI has been changed, that the hypervolemia by itself does a significant harm. And as a responsible physician, our first rule, to be sure, do not harm. So the bullet point I think is important too. And then it's usage of the machine definitely is a great tool for those patients.
Great. And Dr. DeVita?
Echoing that, time is of the essence. And I think to emphasize that you want to pull the fluid off while maintaining renal perfusion. And I use this term a lot. You want to siphon off the fluid. So you want to keep that head of pressure going into the kidney, making sure the kidney is perfused. So you're monitoring the urine output, but you're siphoning off all that extra fluid in a timely manner.
Great. And then Dr. Beckles, and again, thank you for sharing this important research with us today. So what are your pearls?
I echo what my other panelists are saying, but just want to say that when you have a complication in post-cardiac surgery patients that could be as high as 50%, you want to be able to have the technology that's been around for more than a decade and proven decongestion really works to remove fluid. And I think that's what this paper highlights. By pulling fluid off independent of the creatinine, just clinically, the patient is fluid overloaded. Just getting that fluid off gives you great results for the patient, for the community, for yourself, and for everyone else. So go for it. Start the program.
Great. Well, thank you all so much for your time. Thank you all of those in the audience today for your time. And again, this will be available next week on our YouTube channel. So with that, I hope everyone has a wonderful upcoming holiday season.
Enjoy.
Thank you.
Thank you.
Take care. Bye-bye.
Bye.
Thanks, Linda.